Well, transplant procedures have changed quite a lot over the years. And when I was transplanted in 1989, the procedures were quite different from what they are now. But I developed a severe illness, and I knew right away that I was deathly ill. There's something within you that tells you when you're just having mild symptoms or something is seriously wrong. And that occurred about the end of January. And so I saw my doctor, my hematologist, and they did a biopsy and confirmed that I was in liver failure. And I was put on the list immediately for that. And then I went by ambulance from here to Pittsburgh, which was at that time was one of the big centers, and still is the big center, but probably the only center around that was doing transplants on a regular basis. And then I went up to Pittsburgh to be evaluated to see if I would fit their criteria for being a good recipient. And that there are a lot of criteria for that. One is, can you stick to your medication regime, which is complicated? Do you have some kind of social support? Do you have people around you who could help you? Those kinds of things are important in determining whether or not the transplant will be effective and whether the patient will survive it. And then we just waited for an organ to become available, and one became available, and I was transplanted. I hadn't thought about it because I thought I was too old for it. Most of the transplant recipients for EPP were younger than me, and I thought I had passed that window. And it didn't occur to me until I faced the issue that, oh boy, I guess I'm having a liver-related problem because of the EPP. And yes, I did face it then, but I hadn't given it much thought before that. I was grateful to wake up after the transplant. I'm still grateful to wake up every morning because the alternative is not waking up. You have to be suppressed immunologically when you get a transplant because it's essentially a foreign tissue. And that's one of the functions of the immune system is to eliminate foreign invaders, largely pathogens, but it will also eliminate whatever foreign tissue shows up in the body. And so when you take the immunosuppressant drugs, you're on a constant kind of knife edge. Too much immunosuppressant drug and you're susceptible to opportunistic infections, the kinds of infections that people with normal immune systems don't get. And if you have too little drug, then you risk a rejection of the organ. So you're constantly balancing, and even up to now, and it's more than 20 years after my transplant, we are still constantly balancing that by routine blood work, keeping up with whatever the numbers are. So sometimes that balance goes awry, and I had a couple of rejections where the immune system overrode the immunosuppressant, and it became an issue because I was rejecting the organ. Now, you reject a liver, you can't survive that. If you reject a kidney, you can back up on dialysis, at least temporarily. But there's no dialysis for liver transplants. They're working on it, and it's looking good, but not yet. So we have to increase the immunosuppressant. And the immunosuppressants are very, very dangerous. They will predispose the patient to any kinds of immunological infections. And I did have some very serious consequences of immunosuppression. I had a fungal meningitis. I had hepatitis, I had cytomegalovirus. Those first few years were difficult. And those years, actually, the immunosuppressants that I took were cyclosporin and prednisone, which are immensely dangerous drugs. But the procedures have changed quite a lot in those years, and the drugs that I'm on now are much easier on the immune system and much easier on the kidneys. One of the big problems about being long-term suppressed is that you can run the risk of kidney failure. So yes, I have some renal impairment there. I'm down to less than 40% kidney function now. But, you can survive that. At least 40% is better than nothing. And you manage to weave your way through all of those obstacles. I have the immunosuppressant called Prograf, and I'm on 2 different doses of that. Originally, I was on the same dose twice a day, but that was too toxic, and I had to reduce the dose. I'm on another immunosuppressant, mycophenolate. And between those, the 2 doses of Prograf and the mycophenolate, we managed to keep the immune system at the right level where it can effectively get rid of some pathogens, but also not reject the liver. And then I'm also on a blood pressure medication, atenolol, because one of the problems is the renal issue with the immunosuppressant, and the kidneys control blood pressure. So we have to be careful about that renal issue and the blood pressure. And then for the EPP, I'm on a drug called Actigol, and what that does is that allows the bile to flow more easily into the intestines. The liver, one of the major functions of the liver is to break down old hemoglobin and excrete it into the intestines as bile. So if you don't have a good bile flow, and I, of course, no longer have a gallbladder from the transplant, then the bile has to flow more freely into the intestines, and so that drug helps that happen. And the other drug is cholestyramine, and what that does is that interrupts the ability of the body to reabsorb that bile. The body's a great saver. The body reuses as much as it possibly can, and so it wants to save that bile to translate it back into heme. But we prevent that by binding it in the intestines with this drug. So those are the drugs for EPP. Let's see, and then I have a few vitamins and minerals and iron that I take, just calcium for just general health. Part of the screening process was to consult with a dermatologist. And I did do that. And of course, had no skin cancer because I never am exposed to the sun. So that's a big prevention there for that. Yeah, but the immunosuppressant will also predispose you to other kinds of cancers, particularly cancers of the immune system. And I fortunately have not had any of that. For liver transplant, a lot of the surgery has improved because the surgeons are much more experienced and they have a lot more patients that they can fall back on. And so the procedure takes much less time now than it did when I was transplanted. My surgery took, I'm not entirely certain, 16, 18 hours, which is a long time to be under that kinds of anesthesia and to have your body subjected to that. The times now for transplantation are much shorter. And the drugs are much better. One of the big problems initially when I was transplanted is they kept you on high-dose immunosuppressant for a very long time. And that would predispose you to those opportunistic infections. But now they sort of wean the patient down on the immunosuppressant much more quickly. So the likelihood of developing those kinds of opportunistic infections is much less. I wrote myself up shortly after I was transplanted in a letter to transplantation, giving some information that wasn't available at the time. It was my own information that I ran in my own lab, looking for EPP levels and looking for the protoporphyrin in the red blood cells by fluorescence microscopy. Yeah. This is a model of the torso of the human being. This is the liver. Now, the liver has a special circulation that comes from the intestine through the liver, through the rest of the body. This is called a hepatic portal circulation. Now, one of the things that happens when you have a liver event, like a cirrhosis of the liver becomes very hard. And when it becomes very hard, this circulation is going to be impaired because it's like trying to get fluid through a blood vessel that doesn't expand. So when that happens, the blood is going to back up in the liver. It's going to back up in the hepatic portal circulation. And when it does this, the liver is going to expand. The liver is a great regenerative organ. And when the liver is damaged, it will regenerate itself. Unfortunately, this is not always curative because of the unique structure of the liver. So when the liver is undergoing cirrhosis, the hepatic portal circulation backs up. The liver expands tremendously. Now, this is the normal size of the liver in a normal torso. Now, when I was transplanted, my liver took up the entire abdominal cavity. It came down to the iliac crest. So all of this was compressing my intestines, and it was taking up all of this space in the abdominal cavity. And in addition to the hepatic portal circulation, we also have, as an adjunct, the spleen, which is this blue one here, also drains through the hepatic portal circulation. So when you have a backup in the hepatic portal circulation because of this cirrhosis, the spleen will also enlarge. And this spleen enlarged entirely down this entire left side of my abdominal cavity. So that by the time they went for surgery, it was much more difficult to get this liver out because it was hard and it had enlarged so much that it was difficult to get through all of the tissue to pull it out. So that the hepatic portal circulation was going to be impaired. Now, this can lead to a lot of complications for transplant patients. Because the hepatic portal circulation drains through the intestines, the intestines are then going to become engorged. And what this can do is this can lead to what are called varices. And when they happen in the rectum, these varices are called hemorrhoids. And when they also happen in the esophagus, they're called esophageal varices. And this blood is going to back up in those veins that are draining the hepatic portal circulation through the intestines to the liver. And when they do that, this can be a very serious consequence of liver failure, is that if these varices should burst, the patient would bleed to death almost instantaneously, because there are so many blood vessels, and you can bleed liters and liters and liters of blood out through your intestines if this should occur. Now, when one has a liver transplant, one takes the gallbladder out. So I no longer have a gallbladder. This is largely not a problem. Plenty of people don't have gallbladders, and that's okay. But one of the problems about EPP is that the liver is one of the organs that processes bile. And it turns hemoglobin into bile, and it secretes this bile into the intestines. Now, in the absence of a gallbladder, the bile is secreted almost constantly into the intestines because the gallbladder controls when bile is secreted into the intestines. So I take a drug, Actigol, which frees up this bile and allows it to flow much more smoothly from the liver into the intestine. Will reduce the case of having any blockages here. Because if you have any blockages in your bile duct, that's a surgical emergency and needs to be taken care of immediately. One of the other complications I had is that where there's an anastomosis, not shown on here, between the circulation of the patient and the circulation of the donated liver. These have to be sewed together. This is called an anastomosis. And that can harden up. It's called a stenosis. And I had that. I had almost every complication I think is in the book. And that is a surgical emergency because what it does is it blocks the ability of the liver to receive blood. So I had to be flown to Pittsburgh by helicopter to have this taken care of almost immediately after it occurred, because once you start blocking that circulation, then you're leading downstream to major tissue death. So that's another complication that you can have of the liver transplant, and quite a few surgical patients have this kind of stenosis in their anastomosis of the circulation here.